again, we're going to see some overlap in the diseases that we treated with apremilast and JAK inhibitors. Again, why? We all understand why, because we don't have therapeutics approved for these diseases. So dermatomyositis. So this was the first case series published by, the first case series of dermatomyositis treated with off-label tofacitinib. These were patients of Ruth Ann Vleugels, and you see clinical data here, and on the right, really amazing before and after photos. And if you do this more than once or twice, you will have an experience like this. They really can be effective. Study of tofacitinib in refractory dermatomyositis, so an open label pilot study. And again, up above, you see baseline, 4 weeks, 12 weeks, and then the back, baseline, 4 weeks, 12 weeks, with treatment with tofacitinib. And again here, the point of this is not ever to elevate tofacitinib over another JAK inhibitor. It's just a lot of the work has been done with tofacitinib because it's been around since 2012. So what about lichen planus? So these were 3 of my patients who had failed multiple therapies. And you see at the top the insides of their mouths before treatment, and then down at the bottom, resolution of disease with treatment. This patient in the middle, she also had esophageal involvement, urethral involvement, vaginal involvement, resolved. And there are, by the way, again, just in the interest of time, we're not doing an exhaustive literature search, but there's been a open label clinical trial of ruxolitinib cream that also showed really great results for lichen planus. So now morphia and eosinophilic fasciitis. So these were 2 patients, one patient on the left and 1 patient on the right, who had been treated with many things, and their disease had only progressed in spite of prednisone and other agents, methotrexate, mycophenolate. And you see before and after treatment with tofacitinib, really dramatic resolution of the prayer sign, and over here, dramatic resolution of the groove sign. And then there are subsequent reports of JAK inhibitor treatment of morphia in particular. And then here, again, a really severe case of pansclerotic morphia. An imperfect, not complete result, but so much better than she had done without therapy with tofacitinib. So now sarcoidosis. So there's a really fun story evolving with JAK inhibitors and the treatment of granulomatous disease, both granuloma annulare and sarcoidosis. And this is just sort of a hint at what's happening. And by the way, most of this work has been carried on by a colleague of mine, Bill Dansky, who I believe was here giving a talk about this. But he's a really bright physician scientist, immunologist, who's really kind of developing the science to help us understand these diseases and their treatment. So this, to my knowledge, was the first patient ever treated, a patient with a very long history of sarcoidosis. I had treated her with adalimumab, every topical that you can think of, hydroxychloroquine, methotrexate. Nothing worked. And here, before and during treatment with tofacitinib, dramatic clinical resolution of disease, except for post-inflammatory hyperpigmentation. And then here, this was just really fun, also histologic resolution of granulomas. Just sort of single observation, but really elevating that observation, which I think has gotten us to here with some excitement about treatment of sarcoidosis with JAK inhibitors. These patients often have internal organ disease, which, right, is disabling. Right? Sarcoidosis will wreck your lungs. It can be fatal when it involves the heart. And so we started doing PET imaging of patients. And you see here, look at this big subcutaneous plaque, and then intrathoracic and intrapelvic disease here that completely resolves with the tofacitinib treatment. Here, a patient with cardiac involvement at baseline, and with tofacitinib treatment, resolution of cardiovascular sarcoidosis. Oops. So this was supposed to say granuloma annulare. And so this was an open label clinical trial that we recently published. We were fortunate that Pfizer supported this work to make it possible. Again, right? You want to take a case report and you want to elevate it, and that's hard to do on your own. So with some support, we were able to do an open label clinical trial, and you see 5 patients before treatment, and literally nearly eradicating the disease in all 5 patients. JAK inhibitors are really effective for granuloma annulare. And again, this is Bill's work, really kind of elevating what all of us do by actually putting forth science, not speculation, but science, showing that interferon gamma is a really important mediator of granuloma annulare. It's a really important mediator of sarcoidosis. It's a really important mediator of many of these diseases that are effectively treated with JAK inhibition. So now we're getting close to the end, erythema multiforme. So small case series before and after treatment. A single lesion in a patient who had persistent disease for decades, clinical resolution of disease, and then over here you see histological resolution of disease. So again, it's a really powerful observation, even though it's a tiny number of patients. And then I'm going to finish here, and I'm going to finish with a case report. I think the idea of treating bullous pemphigoid with JAK inhibitors is relatively new. There are now a few case reports. I'm just going to show one for no particular reason, just the one that I pulled. But bullous pemphigoid needs treatment, right? It's an awful disease. Awful, awful disease. Prednisone. Fortunately, now we have dupilumab. But we need more treatments. And here is a really beautiful example of resolution of disease with treatment with upadacitinib. So I think this story, there's more to come. And in conclusion, our patients, right? The reason we're here, the reason all of us attend these meetings, right? We want to learn, we want to advance our knowledge, advance our field, ultimately to take care of patients who are suffering. And it's amazing, right? If we had been here thinking about this spectrum of disease a decade ago, there was virtually nothing. Virtually nothing. Prednisone, methotrexate, mycophenolate, cyclosporin. And now, 2025, we have We've just advanced dramatically. And we still have a long ways to go. So thank you so much for your attention. I really appreciate it.
Thank you very much, Dr. King. We have the questions at the end of the session. So I will introduce my co-chair, Diman Tachi, who will talk about the anti-Th17 biologics and the off-label use.
Thank you very much, Marjorie. After a nice talk of Dr. King, I will go more on off-label use. These are my disclosures of interest, and I will mention it again. And I will start where the IL-70s are approved, because different IL-70s are differently approved in the different indication. And you might see some of them, like for example, secukinumab has a very broad range, where it's used in dermatology, but also in rheumatology, and also IL-17A inhibitors like ixekizumab, very similar to that what also secukinumab has, and compared to the IL-70 receptor antagonist, which is not approved in a lot of this one. However, I would generally try to assume that what kind of a treatment option we are having. And I will start with the first part, where IL-17s and how they differ. You probably may be aware that IL-17 inhibitor can inhibit IL-17A, homodimer, IL-17A and F, and this is secukinumab and ixekizumab. Brodalumab is IL-17 receptor antagonist and it inhibits very broad, compared to bimekizumab, which is IL-17A and F inhibitor, inhibits the homodimer IL-17A and A, IL-17A and F, but also compared to the other IL-17A inhibitors, IL-17F and F. Wonderful. We have clarified this, and I will start from the data that we have from psoriasis, what we have learned, and we usually know this trajectory. A lot of patients who are having a very common disease, like for example psoriasis, they know how important it is that we understand also the pathways in psoriasis. As better we understand the pathways and also the cells which are involved in pathophysiology of psoriasis, we are able to understand how this is implementing in the treatment of the skin diseases, dermatological diseases, but this goes, if you want or not, also hand in hand, also in use in rheumatological diseases, which very frequently accompany our diseases in dermatology. First part of off-label use is how we are doing in our daily practice. Are we increasing the dosage? Sometimes yes. Is this off-label? Yes. For example, the secukinumab, every 2 weeks, now it's on-label in some countries, but in a patient who are obese, you may give also the dosage every 2 weeks instead of every 4 weeks. If you go in literature, you will find out that also efficacy of ixekizumab every 2 weeks is more effective than every 4 weeks. And the difference is approximately 15%. So it means in the off-label use, also drugs which have been approved for a certain dosage have been also used as off-label for the treatment of the patient with psoriasis. Why we are doing this? Especially in the countries where accessibility and affordability of the drug is totally different, sometimes we tend to use less, which is more frequent than to do more and more frequently. Very interesting is this observation just recently published by our colleagues from Spain. What they have done, they treated the patient with bimekizumab, and what's interesting, in some of the patients, if you give only few dosages, the patient have been clean for a certain period of time. So it was like as needed base. It was interesting, they do the dosaging, you know, they do the treatment at the beginning for the first period of time, they do induction, and then they look what is the need, and if they have a need, then the patient receives one dosage or more dosages, so in order to spare less dosages and also decrease the cost. And it's also interesting approach telling us that at the same time we are thinking how can be more cost effective, but also being on label, which is sometimes not always easy. But interesting how is the approach of these colleagues from Spain. So looking on psoriasis again, so we have approval for plaque psoriasis. But what would you do if the patient have erythrodermic psoriasis or the patient is having a GPP? Are you going to treat this patient? Of course you will go to treat the patient. Are you on label if they have only erythrodermic form of psoriasis? Probably not. So you will declare this patient as patient with psoriasis, and then you will treat it. And you might see that in some countries, like for example in Japan, with very small studies, it was sufficient to approve IL-70s on erythrodermic and the GPP. And this is not the case by EMA, and I think also FDA have not approved this drug in such a small studies. But it's telling us that in the future, probably we'll have a need for this indication, since we are having a lot of experience and a lot of evidence also to use them in our daily practice on label and not as we are using now off label. This is a typical case that you probably see in daily practice, patient with a erythrodermic form of psoriasis, and you treat this patient and you are probably, whatever you have done, you have been dissatisfied. And IL-70s are known, they are very fast acting drug. And this is why even if they have erythrodermic form of disease, we are tending to use 70s off-label in the patient with erythrodermic form. But if you put as a coexistence of psoriasis, you are on label. This is that what we have done in this patient, and you might see after 24 weeks, 1 year, 2 years, 3 years, the patient is still good. But you probably may realize, and you will look also some of area like there and other areas, you have always to be cautious to exclude cutaneous T-cell lymphoma. A lot of the diseases are mimicking also psoriasis, erythrodermic form of psoriasis. Therefore, exclusion of cutaneous T-cell lymphoma is part of our work in order to be sure that what we are treating is off-label but on diagnosis. Moving further, what is IL-17 favorite off-label use? It is the pityriasis rubra pilaris. It's very close. Why? Pityriasis rubra pilaris from pathophysiology, very similar to that what we have seen in psoriasis. There are a lot of the similarities to psoriasis, and it's no wonder if you see the number of the patients who are treated with IL-17, it's really very huge, and independently what kind of the PRP the patient are having, 1, 2, 3, 4, or whatever, the vast majority of the patient are having complete response, excellent response, good response, and I think this is a very valuable indication. We see numbers of the patients are coming. There's case series, but if you talk about 28 patients, 56 patients, now we have really very good evidence in a pityriasis rubra pilaris. Off-label use of IL-17 can be a very valuable indication for the future. How does it look like? I just brought you on a very recent publication showing patient with a typical pityriasis rubra pilaris, patient also frequently mistakenly diagnosed as a psoriasis, and you might see that the skin, the signs, the symptoms are improving. This is a short period of time, of few weeks, as you can see it, body surface area, DLQI is improving, itch is improving, telling and showing to us that in the PRP, off-label use of 17 have been established. What about the PRP and CART14 mutation? A lot of talks at the moment. Are the patient responding? Young patient? Yes and no. And this is also in a very recent publication in a patient who have a gene mutation. And it was just recently shown that CART14 might be very interesting, as a mutation of CART14 may be associated with PRP. Learning from that, we'll probably know in the future every drug which may up or downregulate the CART14 might be important in the new indication like PRP, especially to this atypical juvenile PRP, which is also happened in this publication as published, as I mentioned recently. And you see also the child grew up, and you see that also improvement was reported within a period of time of 2 or 3 years. That was able to control the PRP in this child. If you go further to indication which is known to all of us at the beginning, it was started as an off-label use in which disease? In HS. Why in HS as off-label? Because we didn't have nothing at that time point. And after the use of the TNF and approval of IL-17s, now the question is that rheumatologists discovered that, look, we can use it in the syndromes they didn't know in the past. Like, for example, the Papash syndrome. It was described for the first time from dermatologists, is pyogenic arthritis, acne, pyoderma gangrenosum in HS. But this brings also the pathophysiology of these autoinflammatory diseases together. How common are these diseases, and why these diseases can come as a syndrome, but they can come separately, and we think that they are very close from that point of view. We improve also acne as part of this syndrome, and it was interesting to see and also observe pyoderma gangrenosum. In the Papert syndrome, improvement was shown in this patient which was treated with secukinumab before and after. Acne and pyoderma gangrenosum. Very interesting. But imagine now you have another disease, the Suffolk syndrome. It's also rare. We work very close with rheumatologists, and they are very happy if we come together and say, look, this patient is having synovitis, rheumatologist is telling us, and we say, oh, that's what I see, it's acne, and I see pustulosis in this patient, and the rheumatologist will go and look, oh, I have some hyperostosis, this looks more toward a Suffolk syndrome, a rare disease, and then we see that IL-17 before and after is improving in both the patient on the left and the right. Left and the right. What are these patients? These are twins. It's telling us that genetic predisposition is very frequently associated with autoinflammatory diseases. Occurrence of this, the pustule, synovitis, hyperostosis is part of this syndrome, and it is very important for us that we do understand these diseases much better. And I think it was brave from our colleagues to understand and to look more. What could I do in acne conglobata? Could I use IL-17? So off-label use in acne conglobata in 16-year-old patient and also 22-year-old patient after the treatment was the IL-17A and F inhibitor clinical presentation after 8 weeks, after 8 weeks of treatment, showing to us that probably we have a chance to better understand all the neutrophilic diseases in the future, and even acne conglobata is part of this disease and not as we thought in the past. But what is interesting, you may have sweet and sour. I don't know if you like sweet and sour, but sometimes you are treating one indication and then suddenly you provoke the disease. You think, now I know how to treat the pyoderma gangrenosum, but in the setup of treatment of, for example, psoriasis with IL-17 inhibitor, suddenly you get the occurrence of pyoderma gangrenosum. So it's not clear. Why is this happening? This paradox reaction can happen also. One of them was published by my colleague Christian Sadek. He's in the room, I saw him. He's there. And it was very interesting to see that you are not expecting. You're expecting that you will have improvement. Instead of improvement, you have this disease that are coming back. To continue where you stopped, back with bullous pemphigoid, it's a challenging disease. I think Marjorie will also go in this direction with Th2, and it's always looking for a solution for this really very bad condition, and thinking more about this, how we are going to tackle this disease. And the idea at that time point where we're working with the Professor Silikans, it was a very excellent time, also thinking more about this, how we are going to learn more. Can we treat also bullous pemphigoid with IL-17? Can this be a chance? And they looked this very closely. And from that group, you might see here that treatment with the IL-17 inhibitor led to the very fast decrease of BPDI. This is bullous pemphigoid disease assessment and intensity of the disease. And then you might see that also anti-BP180 antigen is going down. Use of the clobetasol, mometasone is also decreasing. That means in this patient, which didn't have any concomitant disease, no psoriasis in the past, so the treatment with the IL-17 inhibitor induced a long remission in this case. Interesting case. And then this group went more in depth and were looking more about the relation. Why is this happening with IL-17? How can it be? And they found out that IL-17A, CD4 cells are more enhanced in patients with BP compared to the control. And trying to explain the network of IL-17 and how the IL-17 in interaction with other pathway, and it looks like that IL-17A is more in the middle, less IL-17RC or RA, and also other cytokines. You might see also the connection to IL-4, and you will come, Marjorie, later probably to this one, showing to us how important it is to understand this much better. Even you can repeat this in a very nice mice model. In a mice model, if you put the antigen in a wild type, you can provoke bullous pemphigoid. But if they do not express, these mice, IL-17A at all, these mice will not get bullous pemphigoid. This was for the first time shown the importance of IL-17 and especially the importance of Th17 cells also in the bullous pemphigoid. And the main source of IL-17, they are CD3 positive cells, so the lymphocytes, a little bit in the part also the mast cell neutrophils, but the vast majority of the cells are really CD3 positive cells. Good understanding by case. But you know, again, sweet and sour, you have the same problem. You treat a patient with other diseases and suddenly the bullous pemphigoid comes while you are treating your patient. And this is interesting. It's also paradox reaction. And the paradox reaction is also very interesting because would I treat today patient with bullous pemphigoid with some IL-17 inhibitor or something else? I think it really depends. It's probably different responses. You might see the role of IL-17 in the very early beginning, and we might see that later on it might be probably driven toward more the type 2 inflammation and not going in this direction, which we thought that neutrophils may be activated and also matrix metalloproteinases may have effect on the production of the BP. So this is also a place for this paradox, and if you inhibit 17, it will go in a different way, and you have a paradox BP. Paradox BP, do we use it? Where I would use it? For example, if you have a patient who are having psoriasis, and psoriasis and BP can occur. It can happen that you have both diseases, like in this case, which was just recently also published, and you might see before treatment, after treatment, patient is doing well, patient was treated with coexisting bullous pemphigoid and psoriasis and bimekizumab. So you see a nice response, off-label use of bimekizumab in patient with coexistence of bullous pemphigoid and also psoriasis. I will come to the end of my talk with something probably totally different. The disease, which is a rare disease, is autosomal recessive disease. We know that SPINK5 gene is involved. And if you say Netherton, and if you are in France, I think you have to be cautious. It can be also Comel-Netherton, because Comel was also one of the authors, but we agreed to say it's Netherton syndrome. And the SPINK5 gene is very important. And usually the diagnosis occurs very early. These patients are desperate. These patients, if you see them, they really suffer for months, years. This patient may have also changes on the hair. You know the bamboo hair, because they have a Trichorexis invaginata. From the skin, ichthyosis linearis circumflexa, what you see if you do the biopsy. But the question is how we are going to treat this patient. And then you go in literature, you look, what can I do? And you find two different strategies. Th2 will be part of measuring, and my part is more, is it IL-17 probably also a chance for the patient with Netherton? Netherton has a barrier deficiency. This is known to us, so the question is, are we going toward the Th2 or Th17, and how can we learn from the rare diseases like Netherton in which direction should we go? We have understood that aberrant kallikrein activation is very important. We understood also the barrier dysfunction. This patient has a lot of allergy. This patient have also atopic-like skin, and we have activation of Th2, Th17, and the question is how we are going in which direction. So in the case, she failed on dupilumab. Our idea was first, let's start with dupilumab, but she failed. And then we thought, okay, let's investigate more closely why this patient failed. And then we switched this patient to the secukinumab treatment. After 4 weeks, 5 weeks, we see an excellent response in Netherton syndrome. Which direction, which signature is this? How we are going to deal with this in the future? Probably we'll use also more genetic, because this patient has a new mutation on the SPINK5. One of my co-workers, Yas Gupta, has investigated this one, say, okay, look, this is Netherton, but this Netherton has a different mutation, which was not described in the past. And then we misuse also results from the science in a spatial transcriptomic. We want to go there exactly and to know what is really happening, not only in the single cell level, but which areas of the skin are important after the IL-17 inhibition. And we can do it today with a Visium HD, spatial transcriptomic, at that level that we will come very close, if not sometime better, than the single-cell transcriptomic. This is opening the door toward of better understanding rare diseases, better understanding how, let's say, pathway IL-17 or Th17 is rearranging the disease, and how can we learn about the new targets in the future. How, for example, the role of kallikrein is very close with inhibition of IL-17. And also come close and see SPINK5, kallikrein, how close they are, and how can we use this knowledge for the future. This is my last slide. I'm not encouraging you to use off-label or this treatment option. But we have no other treatment option. And since we do not have it, we have to do the best of the work. And I really appreciate that we have this off-label session talking everything about that what is not approved. Thank you very much for your attention. Marjorie, it's your turn now.
I see we have some overlap in indications. That makes it interesting. Well, I will talk about the off-label use of the T2 biologicals. I will focus especially on the off-label indications and not on the off-label dosing. We regularly do this, but I think the off-label indications will be most challenging. Here you see my disclosures. When we talk about T2 biologicals, we have three: dupilumab, lebrikizumab, tralokinumab. And we know that dupilumab inhibits the IL-4 receptor alpha and inhibits IL-4 and IL-13, while the other two biologics only inhibit IL-13. And when we want to talk about off-label use, of course, we first have to know what is on-label use. And when we look at dupilumab, you see that's a rather extensive label. Of course, the atopic dermatitis from the age of 6 months, the prurigo nodularis, but also the chronic spontaneous urticaria and the bullous pemphigoids. So I will not talk about these indications because I consider them now on-label. FDA has already approved, and EMA will also come very quickly. Then, of course, we have for dupilumab also the airway indications: asthma, COPD, the rhinosinusitis, and the eosinophilic esophagitis. For lebrikizumab and tralokinumab, it's more limited. It's atopic dermatitis from 12 age or higher, and we have studies in lower age groups running. And the first off-label indication that I want to discuss with you is the nummular eczema. And we all know that nummular eczema sometimes is considered as a phenotype of AD, especially in atopic individuals. But we also know that nummular eczema exists without AD. And there is some clinical and histological overlap between nummular eczema and psoriasis, but also in the immunological pathways. What you can see here is a gene expression analysis of lesional skin. In red you see the nummular eczema, in black the AD, and in gray the psoriasis. So there is a lot of overlap. The most studies that I found in literature regarding nummular eczema are, of course, the AD phenotype. And this is the most recent one, in which was a retrospective single-center experience with dupilumab and tralokinumab, a period of treatment of 52 weeks. Most patients were treated with dupilumab, but also 15 with tralokinumab. And the results were all put together, so not separately mentioned for tralo and dupi. They used EASY as a follow-up, and we see EASY 75 responses at 16 weeks, about 2/3 of the patients. And the most observed adverse events were the new onset psoriasis, and that can be expected because of the immunological mechanism. Also, another study that used dupilumab in nummular eczema in 30 adult patients, and also in this study, nice effects on EASI, pruritus, and DLQI. Now you find only one study with dupilumab in the non-AD phenotype, 6 patients who really did not criteria of AD. They had not a history of flexury dermatitis, they had failed all standard therapy, and the authors described in 5 of 6 of these patients a durable response to dupilumab, that was especially measured at body surface area. Then we come to to the second off-label indication, that's the chronic hand eczema. Atopic hand eczema is in the label of dupilumab, but the other forms of hand eczema is not. And this is a recent systematic review. 20 studies were included, including also RCTs, in more than 360 patients. And all those patients were treated with dupilumab. And we see that dupilumab consistently improved the symptoms. And when we look at the RCTs, we see that 40% of the patients had a hand-foot investigation. A global assessment of 0-1 by week 16, which means nearly no patients left. And 90% achieved the HEXI 75, so that's really a nice result. And there were improvements in all the subtypes of hand eczema, so not only the atopic hand eczema. There was a low discontinuation rate, and the limitation was the relatively low treatment duration, so we expect even more positive effects if you continue treatments. This is a very interesting condition, the chronic pruritus of unknown origin, because I think we all have those patients with severe itch over longer periods without any positive underlying condition. We sometimes see excoriations and lesions, but these are mostly secondary to the itch. And the idea is that both local and systemic type 2 inflammation might underlie the pathogenesis of CPUO. And if you block these type 2 cytokines on the sensory neurons, maybe you can improve the itch in these patients. And this is a retrospective case series in which 15 patients with chronic pruritus with unknown origin were treated. They had a baseline NRS score of 7 or more. There was no dermatological disorder, there were no lab abnormalities, no other abnormalities, no prurigo nodularis. And here you see the characteristics of these patients. Rather old age, about 68. Duration of itch of more than 2.5 years. Starting with an NRS of 8. And at the end an NRS itch of 1. And here you see the curves of the individual patients. It looks very nice, and I think this is a population that is really difficult to treat. You see no side effects in this population, so this is a target that is interesting for further studies. And unfortunately, there is also a study running from the company focused on the chronic pruritus of unknown origin. So we hope to have to see the data of these studies. We also see positive case reports on other pruritic conditions like the uremic pruritus, the reactive perforating collagenoses, the cholestatic pruritus, and the brachioradial pruritus, which are all very difficult to treat conditions. Also an interesting one is the alopecia areata, because now we know we have the JAK inhibitors, and we are used to choose for JAK inhibitors if we have this condition. But before JAK inhibitors were registered for this condition, Emma Goodman performed a study, phase 2A randomized double-blind controlled study. It was hypothesis-driven in patients with alopecia areata. And patients were included with and without AD. And the patient received dupilumab 300 milligram weekly, which is different from the AD label. They were treated for 24 weeks. That was the placebo-controlled phase. And then thereafter there was a 24 weeks open label phase. 40 patients were treated with dupilumab and 20 with placebo. And the primary outcome was the change in baseline score of the severity alopecia tool of the SALT score. And after the 48 weeks, patients were allowed to continue treatment if they wanted to. Here you see the baseline characteristics of the groups, the 20 placebo groups and the 40 dupilumab patients. And you see that the mean duration since last hair regrowth was more or less the same in the groups. Also comparable SALT scores. AD history, a little bit more in the dupilumab group. And on below, the IgE levels. IgE levels over 200 were in a quarter of the placebo patients and 1/3 of the dupilumab patients. When we look at the results in the first 24 weeks, we see that the red line, the patients who were treated with dupilumab, show a very small increase in change in SALT score. But what we see is that the placebo group gets worse, so that makes a significant difference at 24 weeks. Then all patients are treated with dupilumab, and then you see a gradual increase in the percentage of patients with improving SALT scores. If you then stop, you see in the dotted line that the line goes down, and if you continue treatment, it's a very small group, but then you see a continuous improvements. And on the right side, you see the SALT 30 score at 48 weeks, and in the continuous treatment, it's about 1/3 of the patients. And when we look at higher treatment goals, SALT 50, it's 22%, and SALT 75, 15%. So it's not as nice as the JAK inhibitors, but still there is improvement. What the authors also did is looking at predictors of response. And especially they were interested in the IgE levels. And they found that patients with high IgE levels had an odds ratio of 8.1 chance to achieve the SALT 30 compared to the low IgE levels. And there was a nice correlation between baseline IgE levels and change in SALT score. And the baseline IgE levels were also able to predict dupilumab's response with a high accuracy. So that would be nice to select patients who maybe benefit from dupilumab. Patient selection based on serum IgE levels. So this was rather positive, but I think we also know if you use dupilumab or other type 2 targeting biologics, you sometimes also see hair loss and also worsening of alopecia areata. Therefore, this systematic review is very interesting because the authors searched for all the articles relating dupilumab to alopecia areata, totalis and universalis, and they found in total 89 cases, of which 71 had concurrent atopic dermatitis. And then you see that 3/4 of the patients reported improvement during dupilumab, but also nearly 1/4 of the patients experienced new onset or worsening alopecia areata. And if you look at when you combine these data and you look at the patients who improve, you see that the atopic status is not very different from the patient with induction of alopecia areata. And you see that more than half of the patients have dupilumab monotherapy, and the other patients also have other treatments for alopecia areata. And that it takes about 9 months before you see the positive effect. On the other hand, if you have worsening or new onset alopecia areata, it takes about 4.5 to 5 months. If you then extend the interval, which was done in 2 cases, it gets better. And if you stop treatment, it takes about 4 months to have resolution of the alopecia areata. So this is really a paradoxical effect of dupilumab on alopecia areata. And of course there are some theories, because we know that alopecia areata is very heterogeneous, and it's a mixed Th1, Th2, Th17 immune signature. And you can imagine that if you inhibit Th2 activity, you can trigger the Th1 activity. On the other hand, you can also improve the outcomes by normalizing the regulatory T cell function by inhibiting the suppressive effects of IL-4. So beforehand, you don't know really what will happen. So maybe the serum IgE will be some indicator for positive or negative effects, but it still remains challenging. Then we come to the more rare diseases. I could find several case reports with positive effects of dupilumab in pemphigus vulgaris, Hailey-Hailey disease, and Grove's disease. And also various case reports of positive effects on more ichthyosiform dermatosis and Netherton, what we also saw with anti-Th17 biologicals. And this is cases that were described in 2023 of 2 sisters with Netherton syndrome and atopic diseases. And here you see marked improvement of the disease, and these patients both failed on omalizumab and secukinumab. And in this paper, the authors also reviewed the publications of Netherton syndrome treated with dupilumab. These are 13 cases, and in most of the cases, 11 cases were successful, and in 2 cases there was only a temporary response and some side effects, they were stopped, but the other 11 were very positive. And of course, this is a very difficult to treat disease. And you have here a biological with very few side effects, so this is really a nice indication. Hypereosinophilic syndrome, there's also some dupilumab cases. It's a rare group of heterogeneous disease with high blood eosinophilia without an underlying cause. Of course, the most logical treatment is anti-IL-5 treatment, what you can see here with benralizumab and mepolizumab. But there were also 9 dupilumab cases. And in these 9 dupilumab cases, 5 patients had skin lesions, and in 3 patients the skin lesions improved. But what's of course important is the hematological remission, and that was not achieved with the dupilumab cases. But what you can see in green, in mepolizumab and benralizumab, we see more of these hematological remission cases. So this is not a logical indication for dupilumab. On the other hand, the hyper-IgE syndrome is a very interesting indication. And this is a very rare genetic disorder group with a very severe atopic dermatitis, but also recurrent skin infections and pulmonary infections, and also a very difficult to treat group. And this is a publication in 2025, describing 3 patients, 3 children, starting with an 8-year-old boy with an AD hyper-IgE syndrome due to STAT3 mutation. Before dupilumab, more than 50% of his body surface area was affected. And after 3 years, you see that only 2% of the body surface area was affected, and you see a very nice decrease in serum IgE levels. Importantly, no asthma exacerbations and no cutaneous pulmonary infections since starting dupilumab. More or less the same in the second patient, a girl of 8 years old with also STAT3 mutation. Also more than 50% body surface area affected. Already after 9 months, only 2%. And what you see, serum IgE from 50,000 to 787 in 9 months. Skin infections were completely resolved. And then finally, a very young patient, a 2-year-old girl, also diagnosed with hyper-IgE syndrome due to another mutation. AD since very early childhood, but also hospitalization for staphylococcus skin syndrome, recurrent eczema herpeticum, so very severe infections, more than 70% BSA, very much suffering pruritus, difficult to sleep. After 6 months already, less than 10% body surface area affected, pruritus resolved, and serum IgE decreased from 40,000 to about 7,000. So it's a very quick response. And you see some pictures of this girl. When you look at the literature, I could find some cases of hyper-IgE syndrome treated with dupilumab. There were 8 additional cases. You see different outcomes, but they all are positive, decreasing scorat pruritus, infections, and serum IgE. And this is very recent. So in summary, when we look at the off-label use of the anti-Th2 biologics, you see that nearly all studies and case reports were published on dupilumab. We see positive effects in mammillary eczema, also in hand-foot eczema, the chronic pruritus of unknown origin, Netherton syndrome, the hyper-IgE syndrome, and rare diseases like pemphigus vulgaris, Haley, and Grover. Paradoxical effects in alopecia areata, and limited or no effect in hypereosinophilic syndrome. And then I looked at clinical trials, because when you see these nice case reports, it's always nice to know whether also trials are running for these indications. I could find trials running for severe chronic hand eczema, allergic contact dermatitis, and severe hand and foot dermatitis with dupilumab. Also nummular eczema, pruritus, lichen simple and chronicus, the CPUO, keloids, localized scleroderma, chronic urticaria for the younger ones, the inducible cold urticaria, Netherton, a pilot study running, pruritic genetic inflammatory skin diseases, and also alopecia with and without AD. So there's a lot of work going on new indications. For trabecilumab is more limited, alopecia areata and atopic hand eczema, and for lebrikizumab, atopic hand and foot dermatitis. So you see that a lot of work is going on, and I hope that we have more unlabeled indications in the next years. Thank you for your attention.
Thank you very much, Marjolein. We are going to the last talk, botulinum toxin. This will be also interesting, bringing the Botox also to the inflammation. Please, Jelmer, welcome. Also Kryden from Switzerland.
Good afternoon. Actually, I'm a little bit a foreign body in this session, but I was put there, so I was asked and I was invited to talk about botulinum toxin. So for those who are not so interesting, I have fully understanding if you want to have a little bit of sunshine outside. And then a little catastrophe happened because I adapted this talk this morning, and well, the new talk is somewhere lost in the universe. So you have to, I have to give you some not adapted slides. But I will talk, and sometimes you will not see it because I have it in my head, but not on the slide. So when we talk about on and off-label use, we should know what it is actually. When it is on-label, then it is described by the Food and Drug Administration, FDA, and it has a lot of information on these specific diseases and conditions. The drug is approved and is to treat and prevent those specific diseases. And there is a strong scientific background of this drug. The drug is safe, effective, and it is for intended use. And the FDA determined the benefits of using this drug is higher than the potential risk. And then the FDA says, okay, this drug is going to be on label. We give a brand to it. On the other hand, what is then off-label? Off-label is when the drug is used for a disease or medical condition that is not improved to treat by the FDA. Such as chemotherapy approved for one cancer, and you use the same drug for another cancer, as we heard today with all the biologicals. It's also not off-label when it comes in a different galenic, like a capsule, and it is given instead in an oral solution, or if the dosage is different. But it's actually not very rare that we use things off-label, and it is legal. It is not forbidden to do that. So if the healthcare providers, or we doctors, we think that it is for the good health of the patients to give this drug in this condition, we are allowed to do it, and if it is appropriate for the patient. And this is also common, as I said. In fact, 1 in 5 prescriptions written today are off-label use. Now, when we enter in botulinum toxin, I would like to present you this guy. This is Dr. Alan Scott. He is an ophthalmologist in Florida. Actually, he passed away, and he invented the botulinum toxin, and he wanted to have a different tool, a different modality to treat strabism instead of surgery. So before they had to shorten the muscle, and he began to inject in the muscle the toxin, and so the look was straightened. He called this brand Oculinum, but he failed. Nobody wanted it, and nobody actually used it. So it gave a shift to the neurology, where they used the drug for hemifacial spasm and for torticollis, or for specificity in general. And then there came a time where everybody was interested in this medicament, and this is an old slide where I say ubi musculus ibi botulinum. There was not one muscle which was not tried to get injected by botulinum toxin. So in the history then, there was a shift from neurology to dermatology, and this was due to the Carusers. Jean Caruso was an assistant of Alan Scott in the ophthalmological department, and she noticed that if she treated a spasm, hemifacial spasm, that on this side there was wrinkle-free. So the patients came back and said, we also want to have treated the healthy side, because I like this much better when I have wrinkle-free. She told it to her husband. This is Alistair Caruso, and so they published the first studies or case reports in the beginning in '95. This was the first publishing for aesthetic indication of botulinum toxin. These are the guys: Alan Scott, Alistair Caruso, and Jean Caruso, with holding arm on Mrs. Scott. And parallel to that, in the same time, there was another neurologist, and he published in the clinic experimental dermatology a year later that botulinum toxin could also be a new treatment for axillary hyperhidrosis, because he saw the same thing he saw when he treated the spasticity, that they were not sweating on the treated side. And I myself, I read this in '97, and then I began to treat my patients for hyperhidrosis with botulinum toxin. The first treated patient in Switzerland was '97 at the University Hospital in Zurich. So this is a minor Stark test. You can make the sweating visible with Stark powder and iodine Lugol solution, and then you can see the difference between a very severe or not that severe sweating. In 1999, I published the axillary gravimetric data with 52 patients, and I could show in this publication that 2 units per injection point are enough to get a complete anhydrosis. And these 2 units is still actually the dosage which we use nowadays. Again, the minor Stark test, it is always individual. All these 4 patients with different sweating were treated with botulinum toxin for hyperhidrosis. But of course, if one patient, like here, will up on the left side, when he returns a little bit earlier than the one down on the right side, you know why. And so you have a sort of a measurement of and the classification of the hyperhidrosis. It is easy to perform, and it is an excellent prognostic tool. Then first we tried to make these marks, and then we saw that the result was not always as good as it should be, because we still had some areas which were not treated. So I went over and did these circles which are touching each other. So then you really can actually guarantee that the whole area is treated without any gaps in between. I said 2 units Botox or Xeomin or 6.3 units Dysport, depending on which botulinum toxin you are using. And this is how we inject. Note that there is no bleeding, so you go in a degree of about 45 degrees, and you go directly subepidermical in the dermis. And if you do so, there is actually no bleeding at all. Then the problem, if you treat hyperhidrosis with of the hands, of the palms, then you have the problem of anesthesia, because injections in the palms is very hurtful. So we did a block, but the block was not handy. It took long. It was very often it was not satisfying anesthesia, and I had a lot of vasovagal syncopes doing the injections for the anesthesia. So we tried EMLA. This is okay, but it gives a maturation and the swelling of the hand, and you are not very confident with the depth of your injections. Chlorotoluene spray was not working because it is too liquid and it spreads too much. So what we do now is we do first lidocaine iontophoresis for half an hour with 2% lidocaine, and then we use our cryotherapy to freeze each little spot. And I'm going to show you how it works. So the patient was in this lidocaine bath, and now we freeze it and inject. The disadvantage of this technique is that you need assistance. You cannot do it yourself. You need somebody who does the cryotherapy, but it goes very quickly if you are a little bit trained, and the pain on a scale of 0 to 10 is about 3 to 4. Easy to do, and the patient, after you finished it, the patient goes home, has no impact, nothing. And so we went on. We treat everywhere. UB sweating, EB botulinum toxin. You can do it intermammary, submammary. You can do the palms. You can do it in the rima arni. We do it a lot in the front for sweating. We also treat the Frey syndrome. Then moving to some rare indications, off-label indications, like the blepharospasm nigricans. This is like a tick. The eyelashes flare the whole time, and it is very annoying for the patient. And the reason why is it is an overactivity of the periorbital system with a hypertonic contraction, and this fatigues the muscles, and then it begins to flare. These are the injection points. Also, I treat not only the orbicularis oculi, but the whole area to relax the whole area, and that is the reason for the flaring eyelid. Migraine, I'm not sure if, I have to say like this, why migraine is working with treatment of botulinum toxin is not clear, actually. Some say we do have neuropeptides which are blocked by botulinum toxin, like substance P, YEP, or calcitonin. In my hand, I think a lot of these migraines are tension headaches, and that's why I do not take this injection protocol, but I do a little bit more injections like this. I treat also the glabella and the front area, then very important the temporalis area, because there is it's very often the tension which makes the headache, and then also the nuchalis and the back for the tension headache. And with this injection scheme, I have actually almost 100% improvement of the treated patients. This is quite proved that it works in the flushing of rosacea. It is not working for the active and inflamed papulosis rosacea, like form of acne, but for the cuprose and the flushing, it works very well. This is also because of this blocking of the substance P and the vasodilating protein peptide, the VIP. This is a study which is not important, but in any case, they injected on all these sites, they injected 25 units intradermally of botulinum toxin. You have to be careful not to hit the muscles, otherwise you have a problem. I come to that. And then this is the result, the clinical result, and this was done by Peter Veldhuis from Amsterdam, and he showed it also in the VISIA, where you can see that the vascularization is really less. There are quite a lot of clinical data. This would have been now in the talk if it would not be gone lost, that it is really improving. And then other conditions in classic dermatology, like notalgia paresthetica. Funny enough, notalgia paresthetica did not work, and I do not understand why it didn't work. If it works on rosacea with all these neurotransmitters, and if it is true that the migraine is really treated by blocking these neuropeptides, then in analogy, actually the notalgia paresthetica should also work, but it didn't. Where it worked is in androgenetic alopecia, and they say because you relax the muscles, the tension of the follicle is not that high, but I do not believe that, because this is not very scientific. It is rather that it is the growth factor B which is activated by botulinum toxin. Then two words for aesthetic indications. These are the on-label. We do have the three main players in botulinum toxin. This is Vistabel from Allergan, Bocultur from Merz Aesthetic, and Azalur from Galderma. We always call it in the scientific name Ona botulinum, Inco botulinum, and Abo botulinum. But I give you both names that you know what we are talking about. Sometimes you are not familiar with the scientific names. And Ona botulinum is the only one which has the indication for forehead. And this is it then. These are the indications which are on label.